Well, welcome, Duke alumni and friends, to this session of the Duke Alumni Forever Learning Institute. I'm Tish Futrell, the Director of Academic Engagement on the Lifelong Learning Team in Alumni Engagement and Development. And I'm so thrilled to have you here today with us for Locating and Identifying Self. This is the second session in our Sense of Self series, and this session will explore how we build resilience, adapt to change, and find meaning. We will have time at the end for Q&A, so as you think of questions, feel free to drop them in the chat. But you will also be called upon on this session, as mentioned. Also, there will be a brief survey at the end of this session, and you will find that in the chat. To moderate the session today, we are joined by my colleague, Kent Wicker. Since 2014, Kent has served as the Assistant Director of Duke's Graduate Liberal Studies program, where he advises students, serves on master's committees, and teaches regularly. His academic interests include American and post-colonial fiction, satire, the novel, and narrative theory. He is especially interested in multidisciplinary approaches to embodiment and to the lived experience of place. Welcome to the Forever Learning Institute, Kent.
Thank you, Latishia. I'm very happy to be part of this series. It is inspired by the core course that I teach for the Graduate Liberal Studies program, which offers a self-designed interdisciplinary master's degree at Duke. This program brings together both full-time and part-time students of all ages, nationalities, and backgrounds. The core course, entitled The Self in the World, is designed to engage with issues of self, other, culture, and identity from the perspective of multiple disciplines. So we've tried to amplify those concerns in this series. This second session in the series focuses on some of the biggest decisions we humans have to make in life about our health. How do we make it through difficult periods in which our bodies seem to be failing us? How do we cope with fear, uncertainty, and complex medical information to make decisions we need to make and do the things we need to do? Helping us to understand this situation today is Peter Ubel, the Madge and Dennis T. McLawhorn University Distinguished Professor in the Fuqua School of Business. He is a physician and a behavioral scientist at Duke University who explores the quirks in human nature that influence our lives, the mixture of rational and irrational forces that affect our health, our happiness, and the way our society functions. He explores controversial issues about the role of values and preferences in healthcare decision-making, from decisions at the bedside to policy. He uses the tools of decision psychology and behavioral economics to explore topics like informed consent, shared decision-making, and healthcare spending. Dr. Ubel, it is a pleasure to have you here.
Great to be here, and super excited for this discussion. And what I'm going to do, as you heard, if you have a question that comes up, put it in the chat, and Kent will remind me of the question if it's something we need to get to right away. Otherwise, we'll have time for Q&A at the end. But I'm going to start by asking some questions and try to hear your thoughts. And these are not questions where there are right or wrong answers, so I'm not quizzing anybody. I'm happy to do that if somebody wants a pop quiz, but I'm really just going to ask questions to introduce you to where I'm going to go with this. So let me just start by, I'm going to tell two stories, and I'm going to ask you to imagine you're me, the physician, in the case. And you're not going to need any medical knowledge to chime in here. These were both patients that I saw when I was practicing in the VA system. That's where I practiced for most of my clinical career. One was a gentleman in his 70s who had just been diagnosed with localized prostate cancer. It was a very slow-growing cancer in the prostate gland that was not going to do any major damage to him anytime soon, but that could potentially advance to the point where it threatens his health, well-being, and even his life. He was told and understood his treatment choices. They were the following. One is surgery. Let's get that thing out. I've got major surgery. They go in, they remove the entire prostate gland. You got to recover from a pretty major surgery. You're going to have potential side effects of that surgery. They're operating in area with lots of nerves that will affect whether your bladder can work normally, whether you can have normal erectile function. Even sometimes the bowels get affected. And then you could have other surgical complications. But cancer's gone, absolutely gone. Another treatment also gets rid of the cancer. It's radiation. And they're going to beam radiation for 5 days a week for 6 weeks, again, to pretty much get rid of the entire prostate gland. And the beams are going to bump into the bladder. They're going to bump into the nerves that affect erectile function. So once again, a chance of erectile dysfunction or a chance of bladder dysfunction, like having to wear a diaper, things like that. Both that also would eradicate the cancer. You're done. Or third option is let's monitor this. Let's surveil this cancer. We'll check every 6 months with blood tests, maybe every once in a while. We will repeat biopsies of your prostate gland to see if the cancer is advancing. You're not going to have erectile dysfunction from that. You're not going to have bowel dysfunction from that. But you will wonder every 6 months whether the next time you go into the doctor, you're going to find out that that cancer has progressed. So you'll live with that anxiety. He understood these treatment alternatives. And he said, well, doc, oh, and by the way, no difference at that time, as far as we could tell, in that your life expectancy, depending on whichever of those you take. My question to you is, you're me, you're the doctor. And he says, doc, what should I do? What would you recommend that he do? Karen, you have your hand up already, so I'll see if you're ready to answer that question. Karen Lee had her hand up. If you can unmute and maybe. Okay, Cannon, and I apologize if I mispronounced your name.
No, you did it right. Thank you. Here is where I would kind of go with this. I recently had a total knee replacement surgery, obviously nothing to do with cancer, and I've been going through recovery for the last 11 weeks. So I realize what physical therapy does and how much of a pain it is. My perspective would be surveillance. And this is why I talk about it. You talk about the fact that.
And just so I know, just briefly, what would you recommend and why? And then I want to get other.
Okay. So surveillance is what I would recommend. And I would recommend that the patient also has some support from a mental stability perspective.
Fantastic.
So that they can be calm and kind of collected about it.
Mark Fisher. Class of 71.
There we go. Can you hear me? Okay.
Yep.
So I'd go with surveillance too, and I will add to it that in 2007 or thereabouts, I faced pretty much what you just described. I made a choice to do a robotic-assisted laparoscopic prostatectomy with lymph node dissection. I can say all those words because I am a long-time survivor living with HIV. And I didn't know if my system needed to have two hostile things competing inside me. I did it. But now I'm fine, but I would be inclined to go to the surveillance because.
Mark, thank you. Thank you.
That's all. Thank you.
And thank you for sharing yourself. I'm glad you're doing well. I really am. Harvey, just briefly, what would you recommend and why?
So this is something that I deal with regularly. I'm a urologist.
You're not allowed to talk.
Okay.
You're disqualified. One more person, then I want to move on. Meryl, what would you recommend and why?
I was trained as a genetic counselor, and people ask in genetic counseling, what would you do? And my response is, I'm not in your situation. So I would explore with him further what the meanings of the side effects
that's where I'm going to go with this, Meryl. Thank you. So everybody, if you unraise your hand so that I'll know. And in fact, that was my take on it too, Meryl. I'm a primary care physician. He had seen the urologist. He'd seen a radiation oncologist. He really did understand it well, but he was torn because it's a trade-off. It's a really hard decision to make. And I didn't want to tell him what to do. So I gave him an analogy. I said, well, what are you going to watch on TV tonight? And he said, the hockey game. And I said, nope, bad idea. You should watch the figure skating championship on Channel 17. I don't even know if there was a figure skating championship. I was just messing with him. He's like, I don't want to watch that. I hate figure skating. I don't want to watch that. And I said, exactly. I can't tell you what to watch on TV tonight because you know what you care about. I don't. and I can't tell you what treatment to get because it's you that needs to decide what you care about. And he says, I got it, doc. Well, then what would you do if you were me? So we're going to talk a little bit about some healthcare decisions people face. And that's related to a topic I know that you've been exploring a little bit in this program, which is identity. I've had an amazing career. And one of the things I love about my career is I have worked with people where they face some of the defining moments of their lives, and a number of them revolve around identity. I teach undergrads and business students right now, and even PhD students and early career physicians who are trying to define research careers, things like that. People are often trying to figure out their identity. Am I this kind of research or that kind of research? Do I want to be a physician? Or do I want to do something else? How is work going to be my identity, or can I find identity out of work? So I love helping people navigate that. It's always more fun to help people figure out their lives than for me to figure out my own. So that's one of the things I love about it. As a physician, I've also really faced a lot of times where people have major, like their identity and what they care about, it comes to the forefront. And it can be at very dramatic things like end of life, where they have to decide, am I a fighter? And if I am a fighter, does that mean I have to do everything? Or am I quitting if I ask for palliative care or not? And I love helping people try to navigate that and figure that out. In the case of this opening story, there is no right or wrong medical decision here. And it's very hard sometimes for patients to understand that we physicians don't always come to them with, here's the answer to the question, to the quiz. Instead, we have to understand what they care about well enough to know what is best for them, or explain things well enough that they can figure that out themselves. If somebody already had severe erectile dysfunction, maybe the side effect of the radiation isn't going to be as big of a deal because the main side effect they've already experienced. If somebody is newly remarried and has normal erectile function, maybe that is an incredibly important side effect, and that should be taken into account. And so one of the things that I've done a lot of study on, and I think it's a really important thing for all of us, it's because we're all either already patients or we're going to be patients or continue to be patients, is recognizing that the role that our values, our identity, what aligns with our identity and our values is going to often drive medical decisions in addition to whatever medical facts are relevant to the choice at hand. And so in this situation, the most experts think the right thing to do, and I'm guessing that's what we would have heard from our urology colleague, is we would go into a process called shared decision making. We'd help that person understand the pros and cons, and we'd help try to guide them towards the treatment that fit them best. I'm going to now share a touch of data on this. And this is data from a study where we enrolled patients. This was in the VA system, and they were about to get a biopsy of their prostate for potential prostate cancer. When they came back to the clinic to find out the result of the biopsy, we had given them educational material so they understood these three choices: the surgery, the radiation, and the surveillance. So they understood the trade-offs, the pros and cons, and we even also tried to show them that the right choice depends on what they care about, not just what the doctor says to care about. And then we asked them, suppose the biopsy proves, shows that you have some cancer. What would you be leaning towards right now if that was your choice to make? And I'm going to now share the screen and show you not just what they were leaning towards, but what choice they actually got. And so all else equal, if somebody came in and said, yeah, if I find I have cancer, I'm going to go for surgery or radiation, you'd expect that they're more likely to get that than a person who, before they meet with the doctor, said, no surgery, no radiation, I would do the surveillance. What I'm going to show you now is that is not what happened. Actually, I'm going to have to go back on the share this. I'm going to go back. Okay, now I'm just going to walk you through this slide really quickly, okay? And here we have three bars. The one on the left, there are people who, before they met with the doctor, said, if I find out I have cancer, I'm going to get surveillance. The middle group is the one that said, if I find out I have cancer, I might get surveillance, I might get either surgery or radiation, I don't know. And the third bar is, if I find out I have cancer, I'm definitely getting either surgery or radiation. And then the height of the bars shows the percentage of them that either get surgery or radiation. You'd expect these bars to be going up in a direction that fit with their baseline preferences, but it's flat, like what they cared about before they saw the doctor had no relation to what they ended up getting for treatment after they saw the doctor. Why is that? Well, here's what the physician recommended and how that influenced treatment. We find that if the physician said you should get surveillance, they got surveillance. If the physician said you should get active treatment, they typically got active treatment. The recommendation of the physician was the dominant influence on their choice. And that's important. It could be important because the physicians figured out something about their cancer or about what they cared about that directed them to the right treatment. But that's not what happened. We actually, in this study, we audio recorded these interactions. So the patient came in, there was a little bit of chit chat at the beginning. How are you recovering from the biopsy? If you stopped bleeding, how are you feeling? And then there'd be a delivery of the news. And then from the delivery of the news that they had cancer, they'd reach a decision. And I'm going to get to the decision in a minute, but I'm going to start off with a verbatim set of quotes of one visit and how it began when they started giving people the news. It went like this. So we took 12 cores out of your prostate. Cores are these little biopsies. Out of those, there were 3 cores that had cancer in them. The percentage of the cores that was cancer was fairly low. It was under 30%. So out of those 3 cores that, about this long, I don't know how far the fingers were apart, had to be pretty darn close. A third of them had a little bit of cancer in them. So those 3 cores out of 12 says that there's probably not an extensive amount of prostate cancer in your prostate, but we should talk about different treatment options. I'm going to tell you more about this conversation in a minute, but if one of you can raise your hand and tell me just your reaction to like the news that and the way this is being communicated so far, I'd love to hear one person who's not a urologist, one person's take on the beginning of this conversation. Anybody have a reaction to it? Was it easy to, okay, Sudi.
I would say I would feel overwhelmed and confused.
You've just heard the C word, cancer. You've heard 3 out of 12, 30%, a third of them, 3 core, all these different numbers flying around, and you're scared and confused. I agree, but that's okay because the doctor is now going to try to clarify by explaining a scoring system that says how mild or severe that cancer is. It's called the Gleason system, but here's what the doctor says. Yes, so 6 is what we consider the most low-grade, least aggressive looking cancer, but it's just abnormal enough for us to call it cancer. If it were any less than that, if there were less atypical looking cells, we couldn't call it cancer. So it's just enough to get a grade of cancer. And then that goes all the way up to score of 10, which is very abnormal looking and is more aggressive. Low risk is Gleason 6. Intermediate is usually 7s, either 3+4 or 4+3, depending on what it looks like under the microscope. And then 8, 9, and 10 are all high risk. Now, yours was an intermediate risk. It was in the middle. It was 3+3 and 3+4. So just enough of the atypical cells of the grade 4 to make it 3+4, which means you're intermediate risk. Is that clearer now? Anybody want to chime in on that? Susan Perrin, if you unmute yourself, please. There
I
you
didn't.
go.
Okay, I didn't have any additional point in that. I just know it's helpful to hear how you walk through with patients, and so maybe looking for pointers on how that applies to broader life in general.
Yeah, Sherry.
I felt confused, and yeah, and we're all Duke educated folks here.
Yep. Felicia, and then I want to move on.
Yeah, so the word that I keep hearing is risk. That's all I'm hearing. And the numbers are just adding a bit to my sense of panic, even though I was on math team in high school. So I feel like you're sort of talking me around a lot of numbers, but you're basically saying that I'm at risk.
When I heard this conversation, I heard an earnest physician who was trying to say to their patient, I'm really sorry you have cancer. That's, I'm sure, scary, but this cancer is very mild. It's barely cancer. It's really something that's so slow growing, we have time to decide what to. None of this was said, but that's what I think the physician was trying to say. This was barely a Gleason 7. And because they were so immersed in those numbers, they assumed that would be conveyed to the patient. What I think the patient heard was something, and there, I see a few people in here that look at least as old as me, maybe. The old teacher for the Peanuts gang who would just go wah, wah, wah. And I think once you hear the word cancer, I do think most of the other part of the soliloquy just sounds like wah, wah, wah to people. And so this is where I think our identities are threatened, because in this conversation, this person needs to understand that it's a very low risk, very slow growing cancer that is unlikely, very, very, very unlikely to kill them, to end their life. It's not a life-threatening cancer for almost everybody who has it. And for those where it looks like it might become life-threatening, we can find out in time and take care of it. In fact, we don't have to decide this today, this week, next week. We have time to decide even what to do. So we're going to take our time. We're going to come back and talk again. We're going to make sure. And then also just what you care about is what's going to drive this decision, whether you really are afraid of these side effects or you really hate the idea of waiting every 6 months to get tested. That is your decision to make, and I want to help you make that decision. That's what the goal should be of these conversations. We almost never saw that language in these interactions. The physicians were trying to involve patients in the decision, but they did it by trying to give them all this medical information that I think just left them confused. When people are overwhelmed, doesn't make it easier to make decisions. There was a famous marketing study where a marketing professor at Columbia set up jam tasting booths in tables at grocery stores. You know, you're rolling by the grocery store and there's a little table and they say, you want to try some cheese? You want to try some jam? And she set up these tables. And some days of the week, there'd be 6 flavors of jam out there, and you'd try out the jam and decide whether you're going to buy one. Some days there'd be 24 flavors of jam. You know, not just strawberry rhubarb jam, but rhubarb strawberry jam. And so what you found out is when there were more flavors of jam, people were more likely to come up to the table and just check it out. They were even more likely to taste at least one of the jams, but they were less likely to buy a jam. Sales were higher when there were only 6 flavors of jam out there. When people are overwhelmed, even by a simple decision like strawberry or blueberry, when they're overwhelmed by just they opt out of a choice. And a consumer can opt out of a choice by saying, I'm not going to buy jam today, or that shampoo company has too many flavors of shampoo. I'm going to go to the one that's either dry scalp or not dry scalp and be done with it. In medical decision making, you often can't just opt out of the decision. So you just say, Doc, what would you do if you were me? And I think that is a very common thing. And the problem is that threatens the most important thing, which is our identities, our values, what we care about are critical in deciding what we ought to do in these situations. The job of a physician should be to elicit that then. And in these interactions, I'm very sorry to say, it was rare, like about 10% of the time, the physician would not only ask whether the person had erectile function or dysfunction, but would ask how important that was to them. So 90% of the patients nobody elicited that importance of those things to them to even then say, well, given how important you think it is to maintain erectile function, I think you should probably be that would push you away from surgery or radiation. That conversation almost never happened. And so I just would recommend everybody here, when you get into a situation where you face a serious medical problem, remember, there's medical facts relevant to your problem, and then there are your values and your identity and what you care about that are also important. I want to give you another example of what happens when people face medical decisions. They're not just thinking about what are my choices and what are the outcome things, but there's also the decision of, well, if I did experience that outcome, how would it make me feel? Right now, I imagine, you know, most people, I know that when we've asked people, imagine you had this serious illness, this serious disability, they often say they'd be miserable if they experienced those things. But when you survey people who experience those illnesses or disabilities, they often report very high levels of well-being. In fact,
Good.
one study we did, I'm going to tell you about really quickly, was of people who had end-stage kidney failure. They were receiving dialysis at least, 3 times a week. They came in for 3 to 4 hours and got dialyzed. At that time, the annual mortality rate for people on dialysis, if they didn't get a transplant, was around 20%. This is a very sick group of patients who can have to watch their diet and their fluid intake very carefully, who often have a hard time holding down full-time jobs because they've got a really serious chronic illness. That sounds miserable. We wondered, is it miserable? And you can ask people that, but when you ask people that question, are they trying to put up a good face? Did you say such a nice introduction to them when you asked them the question that they were happy and thought they were, how do you know how happy someone is or isn't who's got something like a serious problem like kidney failure? Well, we decided, and you'll know when this study took place by the technology we used Palm Pilot. This was back before there were smartphones, right? But it was one of these personal digital assistants people had. We sent people home with Palm Pilots, and we said, every time this beeps, which was going to happen randomly every night in 90 minutes or so throughout waking hours, we want you to answer the questions. And the Palm Pilot would ask them things like, how happy are you right now? How satisfied are you with life? What was your mood right now? Positive, negative, things like that. And we gave that to a bunch of people who had kidney failure. We gave it to another group of people, same age, race, gender, as the people with kidney failure, but who didn't have kidney failure. We gave them Palm Pilots too. And then we looked to see how happy were they over the course of a week. I'm going to show you what we found there. Oh yeah, to go back to the share screen. We find this is on a scale, let's say this is a scale from -2 to +2, and 0 is like in a neutral mood. We found that people with kidney failure, on average, were closer to 1 on that -2 to +2 scale than they were to 0. They were in good moods the majority of their waking hours. This is over the course of an entire week. And in fact, we did not find a statistical significant difference in the happiness, their mood, moment-to-moment mood, to the healthy controls who didn't have kidney failure. But then we asked each group, imagine that you had kidney failure. To the people who didn't have it, we said, imagine that you had kidney failure. What do you think your average mood would have been this week? And they imagined being unhappy the majority of the time, being in a negative mood, a bad mood, not a good mood. We asked the people who had kidney failure to imagine, what would you think your moods would be like if you didn't have kidney failure? And they imagined being even happier than they were. And what we took from that study was that people emotionally adapt to very serious illnesses, even things like end-stage kidney failure. And they don't even recognize how much they've emotionally adapted to that situation. That people, they find new meaning in life, new purpose. They make new friends in the dialysis center. They realize that what really matters is their relationship to God or to their family or to work, if it's not, say, work that they're no longer able to do. And that while most people would like to get cured of that problem, they actually do really well emotionally. And when you're imagining a health problem, you might not anticipate that you would adapt so well. Let me give you another story that goes along with that and ask again for your take on what you would do. Another patient of mine that came into the VA, he had severe inflammatory bowel disease. And back in that time, there were not some of the really great medicines we now have, very expensive, but great medicines we now have for inflammatory bowel disease. He was on the maximal medical therapy, like all the medicines we could do, suppositories and pills and things we could do, but he was having ongoing symptoms, a lot of diarrhea, a lot of abdominal pain, things like that. Hard to keep his weight up, things like that. His particular version of inflammatory bowel disease could be cured by removing his colon. But that would mean he's likely to have a colostomy for the rest of his life. So he would have a pouch in it. Instead of evacuating through his bowels, he would evacuate into this pouch and then empty that throughout the day as needed. I asked him, I said, have you considered getting a colostomy? I think it would really manage your symptoms if you had that treatment done. And he said, oh God, I'd rather be dead than live with a colostomy. I said, well, I hear you, but next time you go, but are you sure that you would feel that way? So I asked him to go to the GI clinic next time he was there and ask people in the waiting room if they had colostomies and how it was like. He came back to me and he said, yeah, doc, you're right. They all said they were doing great, but I couldn't believe it. What should I have said? Is there anything else I should have said to help this gentleman understand what his life would be like if he ever got a colostomy compared to going on with these really pretty significant symptoms? Anything else I should have done as a physician to help him imagine his future self with or without a colostomy? Should I have persuaded him should I have been pushing hard, like do a sales job, like you really need this procedure, I think your life would be much better? These are the kinds of things that I would often struggle with as a clinician. And this is where, in the first case we talked about, the prostate cancer case, I really felt like people, if they understand themselves well enough, they can help me figure out what treatment is right for them. In this case, I felt like people couldn't imagine their futures well enough to know whether they would do well or not. And I think one of the wonderful things about life is that people adapt to a wide range of illnesses and disabilities in ways they can't imagine going forward. And one of the jobs that I think clinicians have and people in our lives that have is to help us try to foresee that and to try to factor that into the decisions we make. And I'm going to tell a story about that, a pretty extreme story about how well people can adapt to severe illness and disability. And then from there, we'll close out to a Q&A. So I'm going to tell you a story, and I want to give you a couple pictures that go with that story, because I think that'll be really important. This is a story about my tennis partner, Scott. Scott is the one in the middle. You can already see he's got several things going for him. Handsome looks, two kids. He also has a severe problem. He's a Giants fan. So we're going to just forgive that for now. Go Vikings. Scott and I were on the faculty at University of Pennsylvania back in the mid-90s. He was my best friend on faculty there. Like me, he's a general internist. And like me, he was a researcher. Unlike me, he was a basic scientist researcher. I'm more of a part-time ethicist and part-time social scientist. He was a basic laboratory scientist. He went into the lab when he wasn't seeing patients, and he studied molecular models of addiction and tried to find out whether that could help find ways to help people overcome addiction. One of the smartest people I've ever met. He has both an MD and a PhD. He was a very good athlete, at least an endurance athlete. When he was in residency, which back in that time, back when we walked to our school in the snow on our bare feet, but back in that day, that was a 100-hour-a-week job. And he was in Boston in his residency, and still during that time managed to train for, qualify for, and run in the Boston Marathon. So I don't know how you do that working 100 hours a week, but that's the kind of determined guy he was. He was also a tennis player, but not as good of a tennis player as he was an endurance athlete. We would play tennis every week, and it was more of a social thing than a really difficult tennis match for me. He did beat me one time. He never let me forget it. In fact, not long after that, I asked him to play tennis with me again, and he declined. He did that a couple more times. I started mocking him. Are you afraid to play me, Scott? And then I ran into him at a meeting in campus. We walked around across campus together. I said, Scott, what's going on? And he said, Peter, I can't play tennis. I have fasciculations. For the clinicians in the group, you might know that fasciculations, which are tiny little muscle ripplings, so tiny they don't cause any joint or anything to really move. You can just see them trickling under the skin. They're often the first sign of a disease called ALS, also known as Lou Gehrig's disease. It is a terminal illness in which you will lose all ability to move your skeletal muscles. Your heart will still work normally, your bowels and bladder will work normally, brain will work normal. You won't be able to lift a hand, move a leg. Even at some point, your eyes, it's hard to control your movement of your eyes. Scott had a particularly severe form of ALS where the median life expectancy was 1.5 years. I can't remember many moments in my life sadder than realizing my best friend was probably going to die very soon. Scott lived for 17 years. This is him more than a decade later. He had to give up his clinical practice, but he still was able to do research. He had research funding that covered extra help for nurses that would come to his lab, that would drive him back and forth from his house into his lab, and then would help communicate to the lab techs to run the things. He continued to get grant money and to do research on addiction. Having a job where he could still do meaningful, purposeful work was one of the keys to him thriving despite horrific disability, where he really he couldn't talk, couldn't walk, couldn't really. He was basically almost paralyzed, fully paralyzed. He, in addition, he thrived for a number of reasons. He had an amazingly loving and supportive family. He had a wife who's a renowned physical therapist. I do not recommend getting a severe disability. If you do, try to be married to a renowned physical therapist. That definitely helps. He also had, as you saw from the previous picture, 2 young boys when he was diagnosed. And it was so important to his life, the meaning and purpose of his life, to help raise those kids. At one point, Scott was in the wheelchair. He was controlling a computer with his eyes because his hand was too weak to move. And he would look, and when he wanted to make an alert to people who were in the room, he could look at a certain part of the screen for a long time and a beeping sound would happen. I'm visiting his house in Delaware. His wife and I are making dinner. His 15-year-old son and 17-year-old son are there. The house is chaotic in a wonderfully chaotic way. The 15-year-old son is starting to learn how to drive. The 17-year-old son is about to go out with his girlfriend, and the 15-year-old says, "Can I back the car out of the driveway at least in practice?" The two of them start fighting. They argue. Something happens, and then they're like chaos is happening, and all of a sudden the computer starts beeping, and we look at the computer, and Scott has typed in the words, "You're grounded." Even at that time, Scott was the disciplinarian in the family. He was also the one who gave them feedback on homework or on how they performed in the lacrosse game or soccer game they were in, what they could do to do better. He was an inspiration to them, and he was really the unifying force in that family. And having that kind of meaning and purpose, this is what we sometimes don't remember. We imagine if something really terrible happened, we'd fall apart, we'd be devastated, and we might. But we might also find that we turn to the most meaningful and purposeful part of our lives and find so much value in that we have reason to fight and to live as long as we can. Scott lived for 17 years. He died in his sleep. He did not ever withdraw a ventilator. He would have kept living if he could, because he continued to find meaning and purpose. And his kids, this is when they were young. This is around the time he was diagnosed, or a little later than he was diagnosed. This is them later on. This is with the governor of Delaware. He's got a son who both he and his son have been featured in 60 Minutes. Scott, because he was the first person to control a computer with his brain, because he had a cap and he could do that. His son, because he's a PhD researcher who just did amazing research that got featured on 60 Minutes. And his other son is a lawyer, so he failed in that. No, he did not fail. I have a law student son myself, but a really successful lawyer who has worked for a lot of important politicians and things like that. They're an amazing family. They would not have been what they would have been if Scott hadn't been there as long as he was to guide and mentor and help them out. So really, that's kind of what I want to close with. When we face major health problems or face illness or disability, it's important to turn to our core identity, to what we care about. Make sure that that's voiced when there are important medical decisions to make. Make sure we seek out other people with experience of those illnesses or disabilities to see if they can give us insights about things we might not anticipate about ourselves. And remember that we're probably better at coping with and adapting to these problems than we can imagine when we first face them. So that's what I want to close with. And now I'm really eager to hear your questions and talk to you. And I know Kent has been moderating or monitoring some of your questions on chat, but also if you have other questions, please submit them there now. Thanks.
All right. Thank you. Thank you, Peter, for that fascinating discussion. We right now there are not actually a lot of questions in the chat. I will say someone did leave a message talking about whole person care. If that's something you'd want to talk about. It seems to be gaining traction in medical education these days, focusing on the physical, psychological, and spiritual areas to help meet patients' real and felt needs. Duke Med has helped pioneer this approach. Do you have any thoughts on that?
It's, I'm a primary care doc. I always thought that you always took care of the whole person. And I recognize sometimes that we might mean the whole body if we're just too much in the biomedical model. But, at least we weren't just treating their left knee, right? But I'll tell you, yeah, I think we still have a ways to go as a profession, medical system in general, of trying to understand how all these things interact. And I'm somebody who suffers from chronic pain. And I'm amazed at how rarely clinicians have seen local pain that I have and try to figure out what more generally is contributing to that pain and what more general approach. And it wasn't until I figured this out on my own and started seeking out things like mindfulness training, biofeedback training, that I finally got it under control. I have a cousin who's had 25 orthopedic surgeries because everybody just looked at one body part at a time, and that is really not the way to practice medicine. Melissa, I see your hand is up.
Hi, I just wanted to thank you for that excellent illustration of how to get a client to recognize that you can't make certain decisions for them. I'm in a completely different field. I provide certain types of financial advice, but I get that all of the time, and I can't decide for you. I can only present the options in hopefully English and not accountant, and let you go with that. So I just wanted to thank you very much for that really excellent illustration of how to get them to recognize that, they don't want to watch figure skating. Thank you.
No, thank you, Melissa. And I have spoken a lot about this topic over the years, and genetic counselors, we have at least one on here now, and financial counselors are two groups I often talk about who are much better at recognizing that their job is to help people understand which alternatives line up with what they care about. And I'm still waiting for the right fellow to work with. I would love to learn from financial counselors and see if we can help them train physicians to do this better, or study how they present their information in a way and see if that can translate to the bedside. So that's absolutely really important analogy. Thank you.
Peter, we have another question. Nick says, bringing these examples back to the meta topic of sense of self, what can we learn about how challenging situations impact our sense of self more generally? Do you have any thoughts on that?
It really, depending on the circumstance you face, it really forces you to, it's the opportunity to just take a step back and figure out what's important, what's left in life. And that can happen for lots of, moments in life. You near retirement age and you ask yourself, what do I want to accomplish in my life? You finish one job and move to another. I think an illness can do that and often does spur people on to doing that. But sadly, some people get so immersed in the medical details, and the doctors are so much talking about what their potassium level is and what their next chemo round will be, that they might not take that opportunity to step back and redirect themselves to what's important. So that we shouldn't need that to refocus, but it's certainly a time in life where you ought to.
And it comes back to know thyself, right? Knowing yourself can help you know who you are and what your values are. We have another question.
And circumstances can change self, and can change what your values are. And there are times where, like, I used to always value A, B, and C, but I can't do them anymore. Well, what else do you value? And sometimes you have to have a radical acceptance of the things you can no longer do to then shift your energy towards the things you still can do. I saw Harvey had his hand up a second ago.
Yeah, I was just going, first of all, I appreciate what you were saying about prostate cancer, and the new thinking is we're much more sensitive to giving patients time to consider their options and shared decision making, And fortunately, it's a slow-moving cancer, so we have that, unlike some of the other cancers that are out there. But I've always been interested in what people, how they consider themselves sick, the definition of feeling normal or healthy. I've had patients that, like you mentioned, who have had colostomy and are in a wheelchair and so on. And they are, I take care of a lot of patients with spinal cord injury and multiple sclerosis. And they live their lives not considering themselves sick. They consider themselves very well and healthy and active. And it's always interesting how other people who are relatively healthy are hypochondriacs. Every little thing is making them sick.
Especially med students.
That's because they know too much. But it's interesting how we see ourselves as being well or not. And I've always been interested in that.
That's really interesting, and I haven't thought about that much, so I will definitely ponder it. Because there can be a form of denial, like I'm not sick, that you have to hope isn't undermining something important in people's lives. But also, why make your identity being I'm sick? I mean, maybe you're like, you have an illness, that's not your identity. And so your identity might be to focus on things that are much more important than, and yes, secondarily, I've got these challenges. Well, I mean, we all have challenges, right? So I really like that point. I will say one thing about prostate cancer, the interactions, time is really important. And when you have an illness and you have time to make a decision, which isn't always the case, but when you do, take the time. And when you need more time, say, you know what, I'm going to think about it. Can you point me towards things to read? And I'll come back and talk more. Everybody should fight for that. The other thing I'd like to see happen more, I saw a lot of really long visits between urologists and these patients, like really long. And they had tons of soliloquy from the urologist. They were earnestly educating patients. I almost never saw a thing we call teach back. And teach back is when the clinician says, now I've told you a lot of stuff right now. I don't know if I did a good job. What did you hear your three choices to be? What did you hear me tell you were the pros and cons of surgery? What did you hear me tell you were the pros and cons? And I bet if most clinicians did that regularly, started doing teach back, first thing would happen is they'd realize they didn't understand half of what I said. Second is maybe I should say a third of what I'm saying and just crystallize it to the most important thing. And we'd probably spend less time and have better communication than we currently do. That's just my guess. Other questions or comments?
Thank you. We do have a question in the chat.
Oh, great. And then after that, Felicia. But yeah, okay. In the chat.
People seem to react to bad news differently. Some become very analytical and go into problem-solving mode, while others can get more emotional and can get overwhelmed with the situation. As a doctor, do you engage with each type of patient differently?
Oh, such a good question. And of course, there's every flavor in between. And sometimes people who are being very analytical, it's actually driven by very strong emotion. So anxiety is an emotion that often compels people to like seek out information that will help them address that anxiety. And so what looks like just super analytical could be very anxiety driven. And it's sometimes hard to pick that up, and you want to learn how to do that. Second, I'd say is most people, when they make good decisions in life, it's because not just because they've thought it through, but because they have emotions to help guide them. If you, there's a famous book called Descartes' Error that highlights a man who had frontal lobe damage from a big metal rod that went through front of his brain. Every bit of his cognition was intact. He could do math, he could do reasoning, he could be philosophy, whatever. He made the worst series of decisions in his life because he didn't have emotions to guide him. So we can't think of emotions as necessarily being undermining decision-making. They're the right level of emotion is part of good decision-making. Yeah, so as a clinician, sometimes though, you get a sense that like they're overwhelmed emotionally, even cognitively. And that's the time to back up if we have time, and to simplify and to let those things calm down, and then reorient them and talk to them again later, things like that. Felicia, you had your hand up.
I did. And since this is about identity, I'll just say I pronounce my name Felicia. I wanted to come back to the example that you gave of the patient resisting the colostomy and sort of generalize that into a discussion of not just individual identity, but social identity. And the idea of seeing oneself as disabled or not wanting to see oneself as disabled. And, I think that in this discussion, there does have to be some consideration for how societies view the disabled, how societies treat the disabled, and how that might create a resistance to people wanting to have that label or rejecting that label. And it ties in a bit with the example that one of the speakers gave of people, labeling themselves well and healthy. And that could absolutely be an adaptive coping mechanism, but it could also be just a rejection of this stigmatizing label in American society.
Thank you, Felicia. And, I think there's one distinction to make is the distinction between stigma and perceived stigma. Now, if you're stigmatized, and you recognize that you perceive that stigma, but there are also just sometimes the perception that you will be stigmatized is enough for people to influence what they do and why they do it. And I think a colostomy is an example of that, where people think, oh my God, everyone's going to see it, they're going to notice it, and I'm going to be stigmatized in this way. And often people don't notice these things as much as we anticipate, and that's really important to help people figure out. But that's a really important point you make, Felicia. I really appreciate that.
We do have another question from the chat.
Yeah.
Julie asked, have you seen differences in other cultures or health systems about how these conversations do or don't consider the whole patient? Having recently experienced healthcare in England and back in Boston, I was struck by the differences in my N of one experience.
Yeah, I think the thing, I'm far from an expert on what some of the cultural differences are. Some of the things that you'll hear about are just like deference to physicians is stronger in some cultures than others. And even in subcultures within any country, like within the United States, there's subcultures where people are more deferential to physicians and places where they're less. Practicing in the VA, I think there was more deference. I think because they were in the military, they were told to obey authority, and so I almost have to overcome that a little bit. Like I'm not your leader here. I'm your doctor. I'm helping you. So you definitely want to try to be open to the fact that people come in, and then even within a culture, you can't assume everyone's just right in alignment with what the majority of people in that culture how they take things too, because there are a lot of contrarians in the world. Mark, you had your hand raised.
I was just struck by or responding to your comment about stigma and perceived stigma. And I am an out gay man for 50 plus years, and I've been HIV positive for almost 40. And I've worked in the community, HIV community, and excuse me, I have found that yes, there's adversity and stigma, but a lot of times people give that more power than it deserves. And so it's important to work on your self-worth and your and how you go at it. And so, that's the short version.
That's so important. And we have self-identity, and then we have how people look at us, and we should work hard to make sure that how other people look at us doesn't define who we are or how we look at ourselves.
Yes.
Let's see. I've got just one more question. I think we have time for just one more. And it's a little bit further back. I have to find it again now. So how do we go about finding, this is Susan, how do we go about finding the professionals that have an approach that facilitates WPC and recognizing patient values and uniqueness? In a medical crisis, referrals are typically made and plans are set into motion during a time of great confusion. Is there anything you can pass on about that, Peter?
Gosh, so interesting. I had a PhD student who finished a couple years ago, and she scraped data. I mean, she collected like over 100,000 online reviews of physicians and tried to see what was in there. And it's a messy way to evaluate things, but actually a lot of people leave comments about their physicians, their style of interaction. And it can be whether they always felt like the physician was rushed or listened to them or didn't listen to them. And I think if you value that, look for those reviews. And you don't get a random sample of people that leave those online reviews, but if you see a couple reviews for a doc where they're saying, yeah, they never listened to me, I would look to somebody where they don't yet have those negative reviews.
Okay, well, thank you, Peter, so much for a really interesting hour. And thank you, audience, for being here, for your questions, and for being a part of this.
Great. And thank you, Kent, and thank you, Peter, for such a great session, and to our alumni audience for joining us today. Thank you.